sort of vasodilatation in the muscles, and the muscles are actively firing impulses. But if you are having hypoglycemia, then your pulse activity is less. So your actually the cardiac autonomic protection when you're having a cardiac ischemia is going down with hypoglycemia. Eckart said clearly that intensive glycemic control actually improved the cardiovascular health, and they had less of angina, less of fatal MI. But on the other end, they had more of deaths. So that this slide, see, the orange one was less. CV events, section intensive therapy was less, standard therapy was more. Yet we had death, which was more in the intensive arm naturally, and less in the standard arm. So what does it conclude? It concludes that maybe the patient had, the last event is the heart stopping, fine. But maybe during this, just transit, hypoglycemia played a major catastrophic impact. So Eckart, what predicted death? Prior CV events, age. Prior CV event was a major factor. They were elderly, they had coronary ischemic evidence on ECG, on treadmill, on angio. They were very revascularized, few were PTCA cases, few were CABG patients, and they had prior CV event, obviously. So that was, the hazard ratio was 3. And the recent severe hypoglycemia, in the last preceding 3 to 5 days hypoglycemia and death was 3.7, nearly 4, which is a big hazard ratio in terms of confidence interval. These are not very legible slides. Hypoglycemia needing treatment in intensive therapy was 16.2 vis-a-vis 5.1 in the standard therapy. Now, we will come to a rational thinking process initiation in the therapy management. Is what are the glucose lowering agents which give you high risk of hypoglycemia? Obviously insulin, sulfonylurea, and the meglitinides. The low risk are metformin, alpha glucosidase inhibitors, thiazolidines, GLP-1 receptor agonists, and the DPP-4Is. So when we are initiating therapy, we both try to convince us as well as the patients that we are trying to do you good with this arm initially, provided we are being able to maintain the A1C, maintain the numbers well within control. This is a very important slide that after a hypoglycemic event, one goes into a defensive mechanism of snacking. So defensive snacking as a potential mechanism for weight gain in diabetes. Patients with severe hypoglycemia, had almost 7 kgs weight gain, and patients without severe, who were not admitted, had nearly 5 kgs weight gain. So the potential explanation for this defensive snacking is an increase in patients' carbohydrate intake following hypoglycemia due to the fear of further events. So this is again a vicious cycle. We talked about it earlier. Eckart, the side effects of intensive therapy, if we talk about the weight gain, was almost 30 kgs. And they were primarily on insulin. So therefore, what proportion of type 2 patients are overweight and obese in our practice? Yes. A, B, C, D. A, 40, 50. Any other suggestion, any other answers or guesses?
30 to 40?
30 to 40. Overweight today, mind you, is defined as BMI of more than 23 kg per square meter in our population. And obesity is more than 25. 23 to 25 is overweight, and more than 25 is obesity. So again, rethink. 80 to 90. Okay. Sorry, 80 to 90. Increasing BMI is associated with the following. We are all overweight. We are all overweight. By the definition of the World Health Asia Pacific today, as from 2008, we are all overweight. And this is also going down. 23 will become perhaps 22 in the next 2 years. And why are these definitions done? Not to confuse and make you look upset. They're done because at 23 kgs per square meter body weight or BMI, your chance of having complications are seen to be more than one who is having 20 BMI. And from 20 to 23, there's a major leap. So we target that you should be within 23. Right. So increasing BMI is associated with the following. D. Naturally. If you don't look good on the mirror, and the mirror doesn't say, you look beautiful, how do you get the energy for the day? The following drugs are not associated with weight gain. Are not associated with weight gain. The vast majority of people with type 2 diabetes are overweight and obese, right? And this is from the World Health Data. Prevalence of diabetes increases, we know, with increasing BMI. So this is the BMI which is going up, the patients with diabetes percentage going up. Overweight and obesity is an important risk factor for cardiometabolic diseases. We know about the visceral fat, about the abdominal obesity, and how it has a direct link with increased cardiometabolic risk. So excess body weight, especially intra-abdominal fat, adversely impacts many cardiometabolic risk factors, including hypertension, dyslipidemia, insulin resistance, and type 2 diabetes. So if you have more fat in and around the omentum, in and around the liver, or in the liver, fatty liver, then that's going to call for attention to these important aspects. The impact of overweight and obesity on health-related quality of life in people with type 2 diabetes. So these were the people with type 2 diabetes, and this was the the SF36. This is again a score of a health, that's quality of life, or a health risk assessment score. So there you have the score, which is the lowest one, which is bad, poor, is with the highest BMI. And with the lowest BMI, it is on the top. So you see the physical component of the summary score is, you were getting more and more number score down here with more BMI. And what is it tracked against? The APSI says this, the ordinate says maximum MET value. MET value is the metabolic equivalent. So in this short form questionnaire, the metabolic equivalent or the exercise capacity is seen to be much low. The lower it is, and the higher the questionnaire score is. So that means, that goes on to say, the people with lowest exercise tolerance are more depressed, have more poor quality of living. Similarly, this is the Beck depression inventory scoring, same words. Weight gain is associated with low patient-reported anti-diabetic treatment satisfaction. That same treatment satisfaction questionnaire, which goes on to say, we talked about hypoglycemia, this is about weight gain. The more weight gain it is, the score is coming down, right? So therefore, the interrelationship between overweight, obesity, diabetes, and the CV risk, the potential impact of treatment which is related to weight gain. See, this is diabetes. If you have glucose lowering therapy and the sugar is controlled, then naturally we also try to reduce CV risk. But if we have more sugar which is going down and more hypoglycemia, then perhaps this, this blue one will change to violet one and increase the CV risk. While treatment, if you're giving glucose lowering therapy, there is more weight gain, more obesity, that will also precipitate diabetes, will precipitate cardiovascular risk. So this is a complete vicious cycle. We have to find out where to strike, and we have to strike it when it's hot. So most oral anti-diabetic therapies result in weight gain. The conventional metformin, the insulin, the conventional and the metformin is, say, weight gain of kgs less than 2.5, but it will be around 7.5, almost 5 kgs more when you give insulin. With glibenclamide, it will be somewhere in the half when you use sulfonylurea. This is the ADOPT. This was from the UKPDS. 8 kgs weight gain in 12 years. And this was ADOPT study. ADOPT was done to show that the oral hypoglycemics fail to maintain A1C over a period of time. The 2 years, 3 years, 4 years, 5 years down the line, you need to increase the dose of hypoglycemics. And finally, after 5.6 years, you have to go to other modality of therapy, which is insulin. And again, insulin, remind you, insulin will bring in more weight gain, bring in more hypoglycemia. So this was weight gain in ADOPT study. So the glucose lowering medications and the weight profile, if you see the weight changes, the positive and the negative, every above this line is positive, and maximum with insulin around 10. With less weight, or perhaps if weight neutral or weight loss is seen with DPP-4I, metformin, and GLP-1 analogs. Therefore, the hypo-obesity, or the hype on obesity and hypoglycemia, is an unmet need to answer a diabetic patient when you're managing his condition. So you see, hypoglycemia is seen with sulfonylurea, meglinotides, and insulin. Increasing body weight is seen in sulfonylurea, TZDs, and insulin. You don't get them in metformin, in acarbose, in GLP-1 and DPP-4Is. So therefore, the final segment of this course is efficacy and safety of DPP-4